Hi, everyone. Thanks for tuning in. Hopefully, you guys are having a good day. We'll be talking about treatments for Peyronie's disease. I'm Dr. Vinson Wang, and I specialize in men's health, and in particular, Peyronie's disease and erectile dysfunction. So, what is Peyronie's disease, otherwise known as acquired curvature of the penis? So it's a condition where scar tissue develops on the erectile chambers inside the penis. Usually causes a curvature, girth changes, loss of penile length, as well as painful erections. It's important that we distinguish between Peyronie's disease and congenital curvature of the penis because treatment options are very different. Congenital curvature of the penis is a lifelong curve, so a curve from as early as a patient remembers. Generally, there's no worsening of curvature. And then also, there's no palpable scar or plaque in the tissues. Peyronie's is thought to be caused by repeated microtrauma events that occur during sexual activity. So in normal sexual relations, the erectile chambers are under significant pressure, and that can lead to micro tears in the erectile chamber. Our body recovers by forming scar tissue over those tears, and then over time, that scar tissue remodels or flattens out. In patients who develop Peyronie's disease, there's usually a underlying genetic predisposition that leads to more aggressive scar tissue formation, and then that scar tissue does not remodel or flatten out. So over time, you get buildup of this collagen matrix or that scar tissue that causes reduced elasticity, resulting in curvature, girth changes, and loss of penile length. So I like to give this analogy to patients so think of the erection as one of those long circus balloons where you can make animals out of. So Peyronie's disease is essentially equivalent to putting a piece of tape on one side of the balloon. So that decreases elasticity. You don't have that expansion on that one side. You have normal expansion on the other side, and then you get that curvature. The curvature can happen in all different directions: upwards, left, right, down. And so it's ultimately a reduced elasticity event. So symptoms of Peyronie's disease, patients frequently complain of curvature of the penis. Some patients can also have girth changes. Patients frequently will note a loss of penile length. If patients are feeling around in the penis, they'll feel a lump or scar tissue. That scar tissue can be inflammatory and cause penile pain. And also, many patients with Peyronie's disease also experience erectile dysfunction. So all of these deformities can cause quite a bit of bother to patients as well as their partners during sexual activity. Sex can be painful, and sometimes that curvature can affect the sexual performance and the ability to perform in certain positions. In terms of the natural history of Peyronie's disease, onset can be sudden. Some patients describe just waking up one day with that curvature all of a sudden. And frequently, in about 70% of cases, there's no inciting event or obvious trauma. So it's repeated microtrauma events during normal sexual activities. And in about half of patients, the curvature does worsen over the acute or active phase, which is generally for the first year to year and a half. In patients who experience penile pain, the vast majority of that pain improves spontaneously, even if we were to not treat the pain. As the inflammation from that scar tissue improves, as the disease stabilizes out, that pain will disappear. And then it's important to distinguish between the active versus the stable phase of Peyronie's. because treatment options are very different as well. So essentially, surgery is not an option during the active phase because we don't want to operate on a patient to correct that curvature to make it straight, only to find out later that the disease causes worsening that curvature and we have to operate again. So when a patient first presents to a urologist, we will ask a detailed history. We'll gather information on the onset of the disease, what penile deformities they're experiencing, so the curvature changes, the girth changes, any loss of penile length. And then also we will determine the degree of bother. So some patients say sex isn't really painful. They're not really bothered by it. Other patients will say they can't even have penetrative sex at all. We will also examine patients so for presence of that scar tissue that we talked about. And then we'll generally offer an appointment for a induction of an artificial erection with medication to evaluate for penile deformities. So that way we get a more objective idea of the exact degree of curvature, any girth changes that can be subtle. A lot of times we can identify deformities that patients may not even have been aware of. And in certain situations, we will also offer a penile Doppler to further evaluate that scar tissue for calcification. Sometimes the diagnosis is not always clear in more subtle scars. So during the active phase, our goals of treatment really revolve around two things. First is the stabilization of penile deformities. So as you recall from the earlier slide, about 50% of times that curvature worsens. So if a patient comes in with a mild curvature, we don't want to just observe that and find out a year later that that curve is now a 90-degree curve and they can't have any penetrative sex. So penile traction is a good option to help stretch against that scar tissue, help prevent that curve from worsening, and on average can actually improve curvature about 30%. And then the other goal of therapy is in patients with significant penile pain to help patients through that. So frequently we'll offer anti-inflammatory medications. If that doesn't do the trick, shockwave therapy as well as verapamil injections can also help alleviate painful erections. So once the patient reaches the stable phase, treatment options are really guided by by the degree of bother. So if a patient is not sexually active or there's no pain involved or the curvature is mild, it's certainly reasonable just to observe the curvature. A lot of patients will ask about oral therapies. They've done some reading online. There's misinformation out online on oral therapies like vitamin E, for example, where there's really a lack of evidence to support the efficacy of these medications for reduction of penile curvature. Penile traction, just like in the active phase, can be quite useful during the stable phase. So penile traction, as you can see in these devices, relies on applying pressure to stretch against that scar tissue. Patients generally wear that device, so the Restorex device shown here, for about 30 minutes twice a day. The other device I like to use is the PeniMaster Pro. That device does require a few hours a day of usage for it to be effective. The studies on penile traction show that it can take anywhere between 3 to 9 months to see a result, but we can see on average about a 30% improvement of curvature. Next, we have XIAFLEX. So it's the only FDA-approved medication for Peyronie's treatment. It's essentially an enzyme that degrades the collagen extracellular matrix found in Peyronie's plaques. we will inject that enzyme into that scar tissue, and it does take many injections for it to be effective. It's approved for curvatures between 30 and 90 degrees. So kind of you can see on the bottom the different degrees of curvature there. When a patient and their urologist decides that XIAFLEX is the best next step, what to expect from there. So once we order the medication, get insurance approval, patients will get scheduled for their first cycle, essentially a injection on that first visit. Sometimes we will induce artificial erection to reevaluate the curvature and to identify the point of maximal curvature. We'll then reduce that erection, inject the medication into the scar tissue. Patients will then be scheduled for a second injection anywhere between 1 to 3 days later. And then there will be an option for a third visit in another few days for additional penile modeling, so stretching against that scar tissue. Alternatively, patients can also utilize the RestoRx device to help with that stretching. So XIAFLEX is indicated for up to 4 treatment cycles, so up to 8 injections. So each cycle has 2 injections. And a patient does not need to complete all 4 cycles. So, for example, if a patient notices significant curvature improvement after just 1 cycle or 2 injections, then certainly we can decide to hold off on future treatment cycles. The cycles are scheduled roughly 6 weeks apart, and sex must be avoided for about a month after the last XIAFLEX injection of that cycle. So there's a lot of data on XIAFLEX. Several placebo-controlled studies show on average about a 17-degree curvature change, or about a 30 to 35% improvement of penile curvature. And XIAFLEX and penile traction are also not mutually exclusive. You don't have to pick just one of these options. So patients can certainly use XIAFLEX and penile traction together. And the studies on the combination of XIAFLEX and penile traction, specifically the RestoRx device, shows about a 50% improvement of penile curvature. Side effects of XIAFLEX are mainly temporary and usually well tolerated. So essentially the side effects include penile bruising, swelling, pain. There's also a less than 1% chance of a penile fracture, essentially a tear in the erectile chamber. That used to be scarier because historically we used to recommend surgical repair of these fractures. However, more recent literature on this suggests that in patients that develop a penile fracture following XIAFLEX injections, is actually safe to manage conservatively, essentially watching that penile fracture and not needing surgical intervention. If a patient either fails XIAFLEX or chooses to go directly to surgical correction, there's many different types of surgical options that's best determined after evaluation by a urologist, and depending on the deformity seen, the specifics of each individual patient, we'll then make recommendations on which type of surgery would be best. But in essence, there's 2 main classes of surgical treatment. So conceptually, if you have a curve to one side, you can either shorten that longer side to reduce that curve, or you could try to cut that scar tissue out and lengthen that shorter side. Going back to the analogy of that balloon, if you have a piece of tape on one side of the balloon causing that curvature, essentially we could put sutures on the opposing side of that scar tissue on the penis. So essentially putting on a piece of tape on the opposing side of that balloon. So if you blow that balloon up, there's more now symmetric expansion of the erectile chambers, leading to a resolution of that curvature. In the lengthening procedure, so that's analogous to trying to cut that entire piece of tape off of that balloon and using a patch of a new piece of balloon, kind of sewing it back together, thereby returning the erectile chamber to its original state. Now, in patients with both curvature and erectile dysfunction, it doesn't quite make sense to just correct the curvature if a man's having trouble having penetrative sex. In patients with both curvature and a difficult time with rigidity, penile prosthesis can be a great option, sort of like one stone, two birds. So a procedure can help both the curvature and the rigidity. So in the picture on the bottom of the slide, you see after the insertion of the penile prosthesis cylinders, and once that's pumped up, you can clearly see that curvature in the penis there. The patient's asleep for this procedure, so the surgeon can be much more aggressive with what we call manual modeling. So it's essentially applying significant forces to that scar tissue to try to crack that scar against the penile prosthesis. And then after several cycles of manual modeling, here you see the end result, which with a much straighter penis. So we understand that Peyronie's disease can be difficult to talk about, embarrassing to bring up to your doctor, to your urologist, but ultimately there are a lot of treatment options available to help improve quality of life. I have many patients who don't bring this up for many years until they eventually bring it up to me. And they regret not bringing it up sooner and seeking treatment, because that's many years of possibly good sexual activity that they've wasted. Any questions? So I have a question about pills that remove plaque and correct curvature. So that's correct. There's no evidence on any of these pills working to reduce scar tissue to correct curvature. So I would not waste your money on that. And how do you bring this up to your urologist if you can get erect? If you can get erect, do they still have to inject in the penis to test it? So generally, it's difficult to have a spontaneous erection in the office. We will typically use medication to induce artificial erection. That way we can do more detailed measurements, get an idea of the curvature, the girth changes. That's because some patients will bring in pictures, but based on the angle, pictures can be deceiving. And there's actually many studies that show that patient estimation of the curvature is unreliable. And if we're making treatment decisions on how best to correct that curvature, generally I want to get a better idea of that curvature before, say, like we bring a patient to have XIAFLEX or to get surgery. Next question is, can shockwave alone offer therapy or offer improvement of curvature? So shockwave alone can help with penile pain, but there's no evidence to suggest that shockwave therapy can help correct curvature itself. Let's see. What's the testing process? I think this is in relation, in regards to an artificial erection. Basically, patients come in for an office visit. we'll use a very small needle and inject the medication into the penis. It's not as painful as the XIAFLEX injections. We offered this actually for patients with erectile dysfunction who fail oral therapies like Viagra and Cialis. A lot of patients are very anxious about the procedure and coming in for a test dose. But once we do it, a lot of patients are like, "Oh, I wish I wasn't as anxious about it." Most of it's kind of mental and anxiety related to the uh, uh, to the um, to the office visit itself. Do penis pumps have any effect? So vacuum devices are not helpful in terms of correcting curvature in cases of Peyronie's disease. It's more for either erectile dysfunction or in certain situations where there's corporal fibrosis from repeated trimix injections. That can be used to soften that type of a scar, but not a Peyronie scar. We have a question on what is the success rate of surgery to remove scar tissue when XIAFLEX does not work? What are side effects of surgery? So it depends on which surgery we're talking about. But for example, the penile, the shortening of the long side procedure. Generally, these surgeries are very effective. More than 89% of patients have a kind of aero straight erection immediately after surgery. Yes, there's a chance of occurrence of that curve following surgery. In terms of side effects, again, depends on the surgery. With the shortening of the long side, so the penile plication surgery, penile pain after surgery, there can be some sensitivity issues for a few months, and then those sutures that are placed, those knots sometimes may be palpable and bothersome to patients as well. But generally, the surgery is well tolerated. Can straightening help with erectile dysfunction without the need of pumping inserted? Um, Depends on the degree of erectile dysfunction prior to straightening, but straightening the curvature itself generally does not help with rigidity concerns. So, meaning if a patient can't get a hard enough erection for penetrative sex with Viagra Cialis, I generally would recommend against trying to straighten that penis out because they're not going to have the patients aren't going to have a good response after that surgery, even with Viagra and Cialis. Is there any age limit that these treatments should not be used? Well, that's a more difficult question. It's less so age limit, but rather competing comorbidities. Certainly in 90 plus year old patients, I mean, a lot of times they're not sexually active, but if getting anesthesia is a limiting factor, then the surgery is not a great idea there. In terms of penile traction and XIAFLEX, those are pretty benign and well tolerated procedures. So there's not really an age limit as long as patients can be sexually active. A lot of times that feeds into patient preference and what their goals are in terms of seeking treatment. What age of men usually start seeing the curvature? So Peyronie's disease is most common in 50 to 60-year-old patients, although we do see in rare cases young guys in their 20s, 30s that have a palpable plaque from Peyronie's disease. So it is possible in the younger man, but generally in patients 50s and 60s. All righty. Well, if there are no other questions, Thank you for listening to the webinar. And you're welcome to make an appointment with one of us to talk further about the either your or your partner's penile deformities. All right, have a good night.